but we have three wonderful panelists to join today, and I'd just like to briefly introduce them and really then just get out of the way. A warm welcome to Anne Lawler. Anne is a long-term member of the HSE National Patient and Service Users Forum and has recently been elected as chairperson. I'm not sure whether to say congratulations or not, Anne. And she's also a co-founder and chairperson of 22Q 11 Ireland and serves as a board member with Rare Diseases Ireland. So a very welcome, Anne. Nice to see you. We also are joined by Mila Whelan, who has been working in patient engagement since 2015, and Mila facilitates the work of the National Patient and Service Users Forum. And we'll hear from Mila a little later talking about the work of the forum. And also then Nicola Williams, who has wide-ranging experience in patient and service user feedback, advocacy and partnering of patients and families. And Nicola also facilitates the activities of the National Patient and Service Users Forum. So just before I hand over to Anne, I'm just going to quickly read one or two of the comments there just that are coming in. So the insights and lived experiences are important to be considered and included in service, teaching and care provision to ensure that we meet goals and expectations in terms of care, patient-centered care, good quality service, involve patients and their families' decisions regarding the care they receive. So Anne, I think you can see the scene is set there. Lots of good comments coming in straight away, but I'm going to hand over to you, and I look forward to hearing your thoughts.
Thank you, John, and thank you for the invitation to be here at the QPS Talk Time. I'm delighted to be reading those comments in the chat box, I have to say, because it's wonderful that everybody, you know, we seem to have a common cause here, and that's to improve patient care. So as John said, my name is Anne. I'm Anne Lawler, and this is a photograph here of myself and my daughter Anya, who will be 39 this year. She's always been in the health system since she was born, but when she was 15, she was diagnosed with a rare disease. Very overwhelming at the time. One of the reasons being that I was told it was a rare disease, but yet her symptoms and what we lived with were not rare. You know, there's nothing rare about learning disabilities or ADHD or things like that, speech and language difficulties. You know, they might be not typical, but they're certainly not rare. So that was one of the things. And the other thing was, on diagnosis, I was given information about an English support group. And at the time, for me, when there was no social media, so I couldn't connect with any other families. And I felt quite isolated. And I felt as isolated after the diagnosis as I did before it. So and there was no mechanism whereby I could approach anybody in our health service and say, you know, I'm after been landed with this diagnosis. What do I do? Where do I go next? What lies ahead for me? So we were in the dark beforehand, and we were in the dark for many years later, until I decided to go to an international conference abroad. And I went abroad, and it was extraordinary, because I went from knowing literally nothing to 2.5 days of back-to-back presentations on 22q deletion syndrome. And there was about 400 people at the conference, and there was one Irish person. And that Irish person was Dr. Kieran Murphy, whom I have there in the little quote from the Irish Medical Times. And Kieran is a psychiatrist, an adult psychiatrist, and he was at the conference because of there's a direct link between 22q deletion and schizophrenia. And this was really overwhelming to me. But Kieran helped me set up the support group here, because there was no support group. And we went, I started with 3 families, and I think I have just under 200 now, and they're all around the country. And we have an undiagnosed population as well, because prevalence rates suggest that we should have 2,500 young people. So you can see also that that was 2009, and Dr. Sarah Prasad worked with Kieran, and that description there of 22q is exactly what's needed. But how was I, as a mother, going to bring about this multidisciplinary approach? And as I said, there was no mechanism. I couldn't get any, I seemingly couldn't get any further. So in we just grew and grew, and I brought over the experts. I started to go to all the conferences, met all the 22q experts in every discipline. You can see there's some of the disciplines there in the column there, and we started to run annual conferences, and I would bring over an expert. It was very, very important to me that our parents and families got accurate information. So I actually didn't know what I was doing. I was actually building a network. So in 2015, then I was still trying to figure out, how am I going to do this? And there was a lot of research about 22q, and there is a lot of research about it. But it didn't seem to hold too much sway here. So in 2015, we, as a voluntary parent-led group, were not funded. So we don't get any funds, and we have no paid staff. But we fundraised, and we held an international conference here in 2013, and then in 2015 we commissioned an independent mental health researcher to work with us, developed a business plan, knocked on lots of doors, got rebuked, knocked on more doors, and kept knocking, basically. And then we held a European conference here, so we now have a European network and an international network. And then it was more by not, I wouldn't say a stroke of luck, but more just hard work, graft, wearing out a lot of shoe leather, John, going and knocking on doors and doing things like that, and eventually got into HSE disability operations with a wonderful letter signed by 16 different clinicians, because at this stage we had started to engage, and we had the Dublin Cleft Clinic, whom I'm sure you know quite well. One of the surgeons was really championing our cause, and we got into disability operations, and I'm so pleased. I mean, I still pinch myself, John, that this has come about, because there is now a 22q paediatric clinic in Crumlin Hospital. There's an adult clinician who's been in shadowing for the last couple of years, and who is starting to see adults in James's Hospital. And last November, we got a funded care coordinator. It's quite extraordinary. And the difference that this is making to families is quite extraordinary. So I think, partnering, this partnership that we've developed has come from our side, as opposed to the health service side. But I hope it's illustrative of what can be achieved when you do sit down. We had so many meetings with the clinicians, we had so many meetings with the HSE, and continuously building relationships. And it was around that time, 2015, it was really a pivotal year for us, because that was the year the Patient Forum was set up. And I joined that because I had gotten involved in the rare disease space. And I discovered lots of things about rare diseases, like individually rare, collectively very common. And 22q is just one of several chromosomal conditions. So when you put us all together, we're quite significant as a population. And also, rare is a little, it can be a misnomer in a lot of ways, because, as I said, the symptoms aren't rare, and they're all about, access to timely access to services and therapies, a lot of therapies. It's not always about orphan drugs, because there is no cure for 22q, even though there are talks about gene editing and all that stuff. But back at the ranch, the families live with this day to day. It is our normal. So it was interesting then to get into the patient forum and to be listening to other people and listening to the change. I think there's such an appetite for change, John, that when we do things, we do them together, and they are better. They're just better done together. And I would have high hopes that I saw Kevin was there in the chat box, Kevin OFarrell, involving patients and their families in decisions, and that's it. And it's a little bit more than, it's a lot more than participation. It's genuine involvement, and I think to do that, we need to continue to have these wonderful conversations. And I would hope, I would have to hope, and I have great hope and optimism about the new Children's Hospital. I'd like to see a new culture developing, a power sharing culture, if that makes sense. Yeah.
And what's the biggest thing in moving from that experience of advocacy as representation to, like you said, advocacy as partnership or as collaboration?
What's the biggest
difference in moving from doing it as a representative voice versus a collaborative voice?
Well, it means, for me, it's not having things done to us or on us. It's the width. You do things together, and the value we bring, John, because the lived experience of any condition, when you have a problem, you generally can find the solution. I have to say, I instinctively followed my nose, because I had lived with, and I still live with Anya, and she's still my greatest teacher as to what her needs are. So it just becomes so obvious to us, and I think too, we need to start. It was interesting to hear from our new care coordinator that he's not in post long, but he's already seen that the medical piece is a little piece, and there's care beyond medical needs, and I think that's the care we all crave. That sense of community and that social care and that kindness, the kindness that comes with that kind of care. So yeah.
And what are the challenges, Anne, in moving into that space again, moving away from just representing the voice of this any group, to what's the challenge of then becoming a partner?
I think perhaps it's a new way of doing things, John. It's a new way of thinking. It's a different mindset. There's fears, there's anxieties, but like I said, and it is all in around the relationship, because I have now developed a wonderful relationship with the two clinicians that we work with, and next week I've invited the care coordinator to co-present with me at a conference. So this relational aspect of it, and it's often forgotten, and people say, "Oh, I don't have time for this," and it might be time consuming, all right, but the end benefit is just so satisfying.
Yeah.
I am just so, I can't express the satisfaction, the absolute, it's just wonderful to be involved to that degree. And we're developing the care pathway together. It's a lifespan care pathway. It's transferable. It's a model of care, that can be applied. And I think, we have to be prepared, John, to listen to each other on a very human level.
And that takes time. We were talking earlier about making the time, and it takes a lot of time, doesn't it?
It can do, yes. I mean, I've known Mila and Nicola now since 2015, and it has taken that time, because, but if we don't do that, you see, we make assumptions, and they're very often erroneous assumptions, I have to say. So And I think perhaps maybe from a professional, I don't know, maybe somebody might jump in here and add to this. From a professional point of view, it might be seen as you can't cross that boundary, you know, or that's not in my remit and I can't, again, I don't have the time to do that. But I think there are ways and means of getting around that, and very worthwhile. It has been so worthwhile. I'm 15 years now doing this piece, and it's been worthwhile. It was hard, but it's been worthwhile.
Yeah, I think we all make assumptions about our roles, you know, that
Mm.
you know, I must behave this way as a professional or do these things, but
Yes,
yeah, I think challenging those assumptions is really important. Um,
yes.
I might hand over to Mila there and Nicola just to start to tell us a little bit about the HSE National Patient Forum and just its role in I suppose facilitating these conversations and relationships, and then I think we're going to come back together and chat again at the end collectively, and I'm also going to encourage people just to pop their questions into the chat box there, and we'll try and address some of them. So thanks, Anne.
Thank you, John, and thank you for inviting me to this webinar. Very happy to be here and sharing with you what we have learned on this wonderful journey working with patient service users, family members and carers as part of the National Patient and Service User Forum. And you're a very hard act to follow, so I'll try my best, but I think every time I listen to Anne, it never stops to amaze me how she speaks from the heart. She speaks from experience and from the heart. And a lot of the work that we do is about, you know, building up those relationships. So where did it all start? The forum was set up in 2015 following a consultation process on the eligibility for discretionary medical cards. Some of you may remember there was a review being carried out at the time, and there was a need to consult with a large number of advocacy groups, patient representatives, and that's where the idea, I suppose, came about, but also it identified the gap that there was no national group that we could engage with on strategy or policy in the health service. So the membership, there are currently 32 organizations. They're advocacy groups, support organizations. Some of them are umbrella bodies like the Disability Federation of Ireland or the voluntary Federation of Voluntary Bodies. Some of them are smaller groups. So it's a real collective. Some members of the forum are just individual patients or service users or carers. So it's a very diverse group. They have an independent chair, and Anne is a newly elected chair. We're delighted with that. Michael Brophy was the chair of the forum for a number of years before that, and he has done a wonderful job. We were delighted to have him as the first chair of the forum. There's also a co-chair, and the forum has the terms of reference, which are regularly reviewed, and the latest review was in 2021. There are a number of objectives that have been identified by the forum and what they do or what they're about, but the key objective, I suppose, is to collaborate in partnership with the HSE at national level on matters that are important for pretty much anybody or everybody who uses health services. And that kind of sums it up. Collaborate in partnership. They're the key words here. I'll give you some examples of what the forum do, and that will put it in context. Kind of, you know, it's not just an idea, it's not just a group that meets on a regular basis, but what do they actually do? Well, at the forum, they have regular meetings. It's usually every 2 months. During COVID, the meetings, we moved them online, and it has been very successful. So we're now having monthly meetings. I must say that has been the unexpected bonus of the pandemic. We have embraced technology a lot more, and now I think it makes it easier for people to join us at the forum meetings and saves a lot of time and traveling. So some of the examples of the work of the forum, the consultation on medical cards was the first one and the earliest one, and I must say, initially when we started out, it was all about consultation, and we very quickly realized that it's only a once-off event, and it's partnership. It's not a once-off event. It's a continuous process, and it has to start from the very beginning. And there were some of the early mistakes we made when we were bringing in people, asking them for their input when something has already been developed or was drafted, and that was the case with some of the earlier consultations. And it wasn't intentionally, it was just a very steep learning curve for us as well as for people who gave up their time so generously and got involved in the work of the forum. Review of hospital car parking charges was another big consultation piece, and that was actually the request of the Department of Health. And we also learned that it is absolutely crucial for the partnership to be meaningful, to close the feedback loop. It's not just good enough to have a consultation session or to ask for feedback and then nothing happens. What difference does it make? And Anne spoke so eloquently about the difference that it makes to patients or families with 22q and other rare conditions. So people want to know, if they participate or give up their time, what difference does it make? Has there been a change made to a proposed policy? Has it made any difference at any level? It doesn't matter how small. It may be something that's a leaflet that was being designed by a hospital or local group. But if the input has been considered, and even if it wasn't accepted, we need to provide that feedback. We need to close the loop. That is absolutely, I can't emphasize that enough. Consultation on the strategy for outpatient services. And this is something that really brought home to us how important it is to continue the process. There were a number of sessions. There was a lot of feedback provided. So this is when we started moving from consultation to more, it was representation, but also collaboration. How do we make our patient services better? How do we deal with people who don't attend? How would we reduce the rate of people who do not attend? All those important issues. Consultation on the HSE corporate plan. And I think it was really important from the point of view of what is the vision for the future of the HSE, and looking at it from the point of view of people who use the services, what is important to them. And Anne also mentioned the importance of the language when we talk about partnership. It's how we move from talking about patients and staff and the health service. We talk about we all want the same things. We all want high quality, safe, effective healthcare. Patients more so than anybody else, or people who use the services. So it is, and language is important. We said we did. We made a difference, or we brought about change. National patient safety strategy, that was also a very important piece, and we had a number of groups involved in it. The National Patient Forum was one of them, but also Patients for Patient Safety Ireland had a huge role to play in this process. Contact management program, this is one of the more recent examples, and we had absolutely incredible involvement from all our patient partners in this process from the very start when the program was designed. And it was all, as you remember, very much a response to the pandemic, but we brought in people who were experiencing it into the design, how the contact management program was designed, communication with people who were receiving text messages with their results, how they were contacted, all of those important things that were crucial. Access, how people were able to access the app, the design of the app, the patients involved in the design of the COVID Care app. So it was, I think it really showed us the importance of the collective and doing things together, and how important it is to recognize the lived experience. People are bringing the lived experience and combining that with the clinical experience and expertise, administrative experience. We can make the best possible decisions. One of the current examples of the engagement of the forum is Trust and Confidence Program, and this is one of it's a very important piece, and Anne has had a huge role to play in this. It is about building trust and relationships, and it does take time, and I think we are learning all the time from people, from our patient partners, but this is one of the key points, I would say. Trust, confidence, relationships. Give it time and let it grow. And just to sum it up, we can move to the next slide, but we've kind of talked about the key learnings already, and Anne has already mentioned a lot of that. It is important to recognize that we all bring something to the table, and the people who have lived experience are there, they're willing, they're ready to work with us, and it's important to share power and not just, I would strongly advise you, it's very important to avoid tokenism, because it's not, you know, it does not achieve anything, and sharing power will give us the best decisions. And I just want to finish with a quote by Lucian Leape: "If patient care is on the table, then patients must be at the table, every table." Thank you very much. Thanks, John.
Thanks, Mila, and I note Anne's comment there in the chat. We'll pick up on that in a few minutes. Thanks, Anne. Nicola,
Hello.
do you want to tell us? Thanks.
Well, as Mila said, somebody has to go last, and I've got two very huge shoes to which to follow in. But really, what I want to talk to you about today is the importance of plain English and clear communication. And really what that equates to, it is the difference between partnering with patient involvement partners or simply not. You'll see there on the first slide, there's two examples of flyers and leaflets which have been developed. So initially, when Mila and I have been working through this over the last previous years, we developed a checklist, and the checklist really was about the importance of that it has to be done at the start. Who is going to support and mentor patient involvement partners? And over time, frequently asked questions kept arising, what people really wanted in essence to know the answer to. So i.e., what is the aim? What do you want from me? What is the time commitment? How many meetings are you asking me to attend? Are you going to pay me? And really, this is what the flyers do in really clearly communicated, plain English. It identifies and answers all the frequently asked questions. And in so much so, you'll note there the one on the left, which is the pre-hospital emergency care around community paramedicine. Initially, when that went out with terms of reference and asked to identify patient partners, it was the first time we never got any expressions of interest. And by taking the time to basically put it into plain English, we then moved to a wonderful situation with supplier being developed where we actually got an oversubscription and we had to shortlist. And when we went back to people and we said, but why, what does community paramedicine mean to you? And they couldn't see themselves in that healthcare journey. And as a result, then, because they didn't mean, it wasn't relevant to people's lives. But when you took the time to say, you could have actually got treatment in your own home. You didn't have to go to A&E and wait in pretty poor conditions, sometimes in the cold, for 17 hours. It could have been done in your own home. Then all of a sudden it was like, oh, we didn't understand. So that really is the key. Emil and I are in this privileged space where we get to engage with patient involvement partners every day. And we know that this is where the magic begins. And as Mila and Anna both said, this is our health service. We all want the same thing, but it's taking that time to develop it. And literally, if we don't communicate well, if we continue to use terms of reference as the mechanism to try and attract patient partners, it doesn't work. So if you go down to the second slide there, Nomi, just the one, yeah, all the resources are there, the checklist are there. It shows the kind of the learning over the years that Mila and I have gleaned, that what works, what doesn't work, the importance of clearly communication with people at the start, not in the middle, not at the end, not rubber stamping, just use plain English.
That's great, Nicola. Thank you so much. And they're great resources, and people may want to tap into them later. And just again, encourage anybody just to your questions or comments into the chat there. Some nice feedback already there from Kevin, just thanking Mila and Anne and Nicola, and just thanking people for the guidance, you know, and I think just to pick up on that, you know, how important is having the process in place and guidance and things like that help us to, I suppose, to accelerate this or to make it happen more easily. And is that important to this work?
It is, John. It's very important, and it's also important to model it. I think it's more
Yeah.
important to model it, actually. Do you know? And I'm thinking back to what you said earlier about what are the challenges, you know, and I think it's really important to hear from the workforce also. What are their challenges, you know, because they need to have the freedom, I think, to bring their ideas. I was talking to a wonderful nurse in the 22Q clinic, because I go to the clinics, and she said, when we were talking about the new children's hospital and something, I can't remember what the topic was, but she said, how would I know? She said, no one ever asked me. You see, so you know, there's a job of work to be done also with, especially because what triggered this in me was the trust and confidence part. Because if you're working anywhere, doesn't matter where it is, if you don't have the trust and confidence internally, you can't have it externally. It just doesn't go, you know. So I would love to see more of this openness and this transparency and this honesty, and people feeling that freedom, so that they're not going to feel that they're going to be judged or criticized or anything like that for bringing their concerns or their uneasiness or whatever it is, you know. I would really like to see that. And I know we talk about this, John, and I think they're what's become known as soft skills, and really they're just human skills, you know. They're
Yes. Yeah.
it's
Yeah.
just us all being human together, basically.
Yeah. Yeah.
Yeah.
Absolutely. And I think, you know, as people say that the soft stuff is actually the hard stuff, because they are
Yes.
human skills, but they're hard to do. And I think that
Yes.
idea of person-centeredness or collaboration is everybody collaborating, you know, not just patients and staff. It's staff together, patients together. I
Yes.
think it's the principle, isn't it, of
It is,
collaboration.
yeah. And you're right, and it can be very messy and
Mm.
chaotic and all of that, you know, but that doesn't mean to say it's impossible. It's doable, you know.
I suppose a question I would have to everybody is the idea that, you know, and I think Anne mentioned the P word earlier about power, you know, and
Mm.
is power moving fast enough? You know, are we kind of, you know, taking power from the center and bringing it to people who should be, you know, in a place to help make new and better decisions? And obviously that has to be done in a safe way. But you know, it's hard to see partnership happening if the power isn't moving.
Mm. Yes, that's the thorny question, I think, John. But you know, somebody described me, and I hadn't seen myself this way, as a patient leader. I'm not quite sure what that means, but I think, you know, we're all leaders in some role or another, you know. And if we start to shift again the mindset towards a we leadership, so that we're leading together, you know, and sometimes that's I step out and you step in, and I step out and you step in again, you know. But I do think it's a new way of, maybe not a new way of thinking, maybe that the thinking has always been there. It's just a new mindset, you know, that
Yeah,
yeah,
yeah.
level the playing field, you know. I always remember starting out, John, and I was so green. Oh my goodness. And I said, how am I going to present myself as equal to these people I'm meeting? So it's like when I mentioned Alf Nicholson. So when I met him first, I didn't call him doctor or professor or whatever his title is. I don't do titles. I simply called him Alf, because that was my kind of, that was to give me the confidence to speak on an equal footing. You know, you might be this really good doctor or whatever, but you're a human being. I'm a human being. And that's the way I proceeded.
Yeah, no, I totally agree, and I think titles and things get in the way often of just that human connection and being able to talk openly. And I
They do
think
indeed.
certainly
Yeah.
breaking down hierarchies is part of this as well. I'm
I,
gonna
do you know what I'd
sorry.
love, John? I'd love to see some co-training. You know, when you're doing leadership training, that it's not every patient now wants to be a leader, I have to say.
Sure.
They're not all bonkers like me. Um, but to have that opportunity to work, to learn together, I think that would be so useful. I'd love to see it happen.
Yeah, absolutely. More of it. A question there from Thomas Rue. Boots on the ground. What are the practical steps a new healthcare initiative can take to involve patient partners? Mila or Nicola, do you want to maybe address that one? And I think you've been sharing with us already some resources and steps.
Yeah, no, I'll try. Some of the resources might help you. There is guidance on recruiting patients or people with lived experience. So depending on what service or what initiative you are starting, look for people who will be using your service and then recruit among them. There are some practical tools on how to do that. To be honest with you, we have the added challenge working at a national level. We don't actually have day-to-day contact with the patients or family members, which is an added challenge. And we do overcome it by contacts, networking, talking to people, talking to organizations, talking to people working in hospitals and CHOs, and that's how we have recruited people for the patient representative panel. So start from that, and also I can't reiterate enough, start from the beginning. So when you're starting your service or the initiative, bring in people then, have a brainstorming session, a focus group. As Anne said, it can get messy, but have it from the very beginning.
And I think that's a critical point, isn't it? That's a critical point. It's never too early, to bring people in. Yeah.
And don't make assumptions that what patients or family members look for will be completely unreasonable or will be, just not something that can be achieved. Have that conversation. Listen. There is so much creativity. There is so much a willingness to work with us, and you may be completely surprised. There may be solutions and ideas that we wouldn't think of by working in the service. We're focused on certain things. We're focused on the task. We're focused on delivering plan, which is what we do. That's our job. But bringing people in who have the experience of living with something or experiencing it firsthand, it really opens up possibilities and opens up ideas. So don't be afraid. Bring them in from the very start.
And Bernie O'Reilly there, just picking up on Anne's idea, and I think what you're kind of getting at there is, it's the idea of co-training, is that we should train people to do, not only to work from the start, but we should train them together, and
Yeah.
what a good way maybe of bringing patients and professionals together, through training and bringing some of these ideas, to bear there.
And we have done some of it, John. We had a very good session with Eleanor Rivoire from Accreditation Canada a few years ago, and it was a session that was open to members of the forum, members of patient safety, staff from hospitals, from our colleagues from the QID. So it was a fantastic event. We had everybody in the room. It was a workshop event, and I would agree with that completely. Training together is really the way to go.
And I think it's important to say that we're all learning at this. This is a new way of working everywhere around the world, and I think there are people who are, maybe exemplars, to pick up on Anne's word from earlier, of good practice. But I think we're all learning how to do this, and I think it takes practice, and I think we probably, all need to be getting involved in this to get the learning and the skills up to really get the return on it eventually.
And learning by doing, not to build up assumptions. Just take the leap of faith and do it. And I can tell you that it really is the most rewarding process, and the results will always be far better than if we were to do it, without any collaboration.
John, I just wanted to, Maeve Carmody has a question up there about reimbursement. So there is, I've just put it up in the chat box as well, there is the PPPG, the policy procedure and guidance document. There is one for the reimbursement of out-of-pocket service user expenses. So that deals with it. The Department of Health is still doing a scoping exercise around what they're calling voice partners. So in the future, that will dictate how people are paid, but it's not at the races yet. It's still very much at scoping level. So we can only go on what is there. So no, at the moment, we're not in a position to pay patient involvement partners, but what we can do is reimburse out-of-pocket service user expenses.
Yeah.
That has to come from whichever division or directorate. There is no national purse on this. It comes locally with wherever the point of engagement is happening.
Great, thanks for that, Nicola. And like you said, we're all feeling our way into this and learning how to do it better. And I think it is clear, however, I think that the world is changing. And I think that quote from Lucian Leap, at the table, every table, I think is starting, I think, to really be appreciated at this stage. And I think for so many reasons, I think simply it's the right thing to do, but also from the energy it brings, I think, to solving problems, to the ideas, to the perspectives that are lost by not making that table larger. I think I think this is certainly something that we should all be welcoming. So I want to thank everybody. I think we're probably out of time, unfortunately. Again, you can see lots of nice comments and questions there. People again thanking you for your resources and looking kind of to suggest some other good resources. The Hemingway app someone is mentioning there. So I'd like to thank our panelists. Thank you so much, Anne. It's been a pleasure.
Thank you, John.
Thank you, Mila. Thank you, Nicola. Again, I'd like to encourage everybody to register themselves in the QPS Ireland network map. Just to let us know, where you are, what you're doing, and that allows us to help to connect you with everybody else in quality improvement and patient safety. Next slide there. And equally, another thing to consider is to join the Q community, and you can contact our colleague Caroline Lennon-Nally if you would like some more information on that. And again, Q connects you to people within Ireland, but also across the UK countries. And then finally, just to put it in your diary for a couple of weeks' time, my colleague, Dr. Rob Cunney from Temple Street, will be running the session here in 2 weeks' time on liberating structures. And I can guarantee you that'll be fun. Rob is very engaging, and the liberating structures are a great way of learning how to engage others. So 22nd of March is our next QPS talk time. So finally, just a reminder, as you go to leave the session today, you'll have a pop-up questionnaire just looking for your feedback. Just how was the session and what is it that we can do better, and maybe ideas for things that we might cover in the future. And like I said, please do put something in there, because we do like to hear your feedback and we use it and learn from it. And that's it. So thank you all for joining us, and we'll see you in 2 weeks' time.